Good evening, everyone. We will be starting the class now. Today topic is nephrology, in which the key focus areas are chronic kidney disease and CKD, mineral and bone disorder. And the speaker we have here is Dr. Jaysurya R, who is a nephrologist at Apollo Multi-Speciality Hospital, Kolkata. And the moderator that we have for today is Dr. SANDIP Bhattacharya. Ma'am, over to you, please.
Thank you. Thank you for giving me this opportunity to present on this topic, CKD and mineral bone disease. Today's topic of discussion is CKD mineral bone disease. The overview of my presentation, I'll be discussing about the definition of CKD mineral bone disorders, pathogenesis of CKD MBD, diagnosis and treatment of CKD MBD, mainly based on KDIGO guidelines. So, as we all know, CKD is a worldwide health problem affecting 5 to 10% of world population, and majority of CKD population are at increased risk of developing disturbances in mineral and bone metabolism. These disturbances lead to a constellation of mineral and bone abnormalities, which were previously termed renal osteodystrophy. So, as kidney function declines and as CKD progresses, there is worsening of mineral homeostasis, disruption of normal serum and tissue concentrations of calcium and phosphorus, and changes in hormones, mainly parathyroid hormone, calcitriol, and FGF23. Patients with renal osteodystrophy not only have skeletal disorder, they are also predisposed to develop cardiovascular and soft tissue calcification, leading to a high morbidity and mortality. So, KDIGO in 2005 coined a broader terminology named CKD mineral bone disorder for the systemic disorder of mineral and bone metabolism due to chronic kidney disease. The previous term, renal osteodystrophy, is exclusively used to describe abnormalities of bone morphology in CKD. So let us see the definition of renal osteodystrophy and CKD MBD. Renal osteodystrophy was defined by National Kidney Foundation in 2003 as a constellation of bone disorders present or exacerbated by CKD that lead to bone fragility and fractures, abnormal mineral metabolism, and extraskeletal manifestations. In 2005, KDIGO coined a newer term or a broader term that is CKD MBD, which is defined as a systemic disorder of mineral and bone metabolism due to CKD, manifested by either one or a combination of the following three features. First is abnormalities in calcium, phosphorus, parathyroid hormone, or vitamin D metabolism. Second is abnormalities in bone turnover, mineralization, volume, linear growth, and strength. And third is vascular or other soft tissue calcification. So we have understood the definition of CKD mineral bone disease. Now let us look into the pathogenesis of CKD MBD. Previously, the two main pathogenic factors for CKD MBD were considered to be phosphate retention due to decline in renal function. As we all know, phosphate excretion occurs through the kidneys, and as the kidney function declines, there is increased phosphate retention. Also, there is calcitriol deficiency. Calcitriol is active vitamin D, 125 dihydroxy vitamin D. As 1 alpha hydroxylation of vitamin D occurs in the kidney, as the kidney function declines, there is a deficiency of active 125 dihydroxy vitamin D or calcitriol. So these two factors, phosphate retention and calcitriol deficiency, were considered to be the major initiators of stimulation of parathyroid hormone, leading to secondary hyperparathyroidism. So the triad of hyperphosphatemia, low 125 dihydroxy D3, and hypocalcemia stimulate increased parathyroid hormone production from the parathyroid glands, and this lead to increased phosphate excretion. So this hypothesis is termed as the trade-off hypothesis proposed by Bricker. So again, progressive nephron loss in CKD patients leading to phosphate retention and leading to activation of compensatory mechanisms like increased parathyroid hormone in response to retained phosphate, ultimately resulting in mineral-borne disease. Later, the pathophysiology of CKD-MBD evolved a lot over the last decade, especially with the emergence of a factor termed FGF23 or fibroblast growth factor 23. So, the understanding of this factor revolutionized the understanding of CKD-MBD pathogenesis. FGF23 is elevated with progressively worsening kidney function even before observed changes occur in phosphate levels and parathyroid hormone levels. So, to summarize, PTH, FGF23, and active vitamin D or calcitriol are the three main endocrine hormones which regulate calcium and phosphorus homeostasis through their effects on kidney, bone, and intestine. So, abnormalities in these three hormones are the major pathogenic mechanism for development of CKD MBD. So this is a pictorial representation of the actions of these three factors. First, let us see FGF23 or fibroblast growth factor 23. It's produced from bone. Major actions are it stimulates phosphaturia and downregulates 125 dihydroxy D. Then and it downregulates PTH production. Parathyroid hormone produced from parathyroid gland increases bone resorption, upregulates active vitamin D, inhibits calciuria and promotes phosphaturia. And 125 dihydroxy D main action is in the intestine, leading to increased calcium and phosphorus absorption. So, PTH, the main stimulating factor is hypocalcemia, main inhibitor is hypercalcemia, and it primarily regulates ionized calcium levels. Main effects are stimulation of bone resorption, inhibition of calciuria, stimulation of phosphaturia, and increased active vitamin D levels. FGF23, main stimulus is active vitamin D and dietary phosphate. It acts by stimulating phosphaturia, lowers serum phosphate, inhibits PTH, and increases 125 dihydroxy D. Calcitriol, the main stimulus is PTH here, and main inhibitor is FGF23, and mainly acts by increasing intestinal calcium and phosphorus absorption. It suppresses PTH and stimulates FGF23. So again, a little more detail into FGF23. It is derived from osteocytes and play a vital role in vitamin D and phosphate metabolism. This factor requires clotho, a transmembrane protein, to bind to FGF receptor in target organs like kidneys and parathyroid gland. FGF23 enhances phosphate excretion in proximal renal tubule, and it decreases intestinal phosphate absorption and reduces the synthesis of active vitamin D. So if you look into this chart, we can see that as the CKD stage progresses, there is a progressive decline in vitamin D and clotho levels, and there is an increase in FGF23, which is the earliest factor to rise, followed by a rise in PTH, followed by a rise in phosphorus levels. So in early CKD, FGF23 attenuate hyperphosphatemia at the expense of white calcitriol suppression, initiating the onset of secondary hyperparathyroidism. Decrease in active vitamin D decreases intestinal calcium absorption, and triad of low calcium, low calcitriol, and hyperphosphatemia increase PTH secretion. So, what are the effects of increased PTH levels? It leads to mobilization of calcium from bone, resulting in increased bone resorption and a pathologic state called osteitis fibrosa. Increased PTH leads to hyporesponsiveness of vitamin D receptor on the parathyroid gland. It further enhances the production of PTH hormone. It reduces the expression of calcium sensing receptor on the parathyroid gland, leading to parathyroid gland hyperplasia. So we have already seen the term renal osteodystrophy. This was a previous classification or the classification of the pathological changes of renal osteodystrophy. It's basically classified into high turnover disease, low turnover disease, and mixed uremic osteodystrophy. And this classification was proposed in 1983. High turnover disease is osteitis fibrosa cystica, and low turnover disease include adenomic bone disease and osteomalacia. And mixed uremic osteodystrophy is a combination of these. And for diagnosis of renal osteodystrophy or CKD-MPD, bone biopsy is not always necessary, and KDIGO recommends biochemical parameters, assay of PTH and total or bone-specific alkaline phosphatase to identify the degree of bone turnover. So let us look into the parathyroid hormone assay, which we routinely use in our CKD patients for diagnosis of CKD-MBD. So there are 3 generation assays for PTH. First generation assays use an antibody to locate the epitope on C-terminal or mid portion of PTH. But the drawback of this is a cross reactivity with smaller fragments of PTH, so leading to falsely high levels. So currently what we use is second generation assay, which measure full length intact PTH along with some smaller fragments of PTH. Third generation assays are the most specific ones, but both second and third generation assays have comparable efficacy. Next major marker, biochemical marker of CKD-MBD is alkaline phosphatase. We have total alkaline phosphatase assay and bond-specific alkaline phosphatase assay. Both are markers of bond formation and mineralization. And there is a good correlation between these two assays. So let us go into the diagnosis of CKD-MBD. We'll be basing our discussion on KDIGO guidelines. So from CKD G3A onwards, that is with a GFR of less than 60, it is recommended to monitor calcium, phosphate, parathyroid hormone, and alkaline phosphatase levels at the time of diagnosis of CKD for diagnosing CKD MPD, and then serial monitoring with at regular intervals based on the severity of CKD. So in early stages, G3A and G3B every 6 to 12 months of calcium and phosphate assay is recommended, and PTH at the baseline and with CKD progression. For G4, calcium and phosphate every 3 to 6 months and PTH every 6 to 12 months. For G5, including dialysis patients, calcium and phosphate every 1 to 3 months and PTH every 3 to 6 months. And alkaline phosphatase activity every 12 months or more frequently in presence of high PTH levels. In addition to this, native vitamin D or 25 hydroxy vitamin D assay is also measured. And if there is vitamin D deficiency or insufficiency, that needs to be corrected as per the recommendations for general population. So for all these parameters, more important than a single lab value is the trend of the levels for deciding on the treatment. Individual values of calcium and phosphate evaluated together should be used to guide the treatment options rather than calcium phosphate product as per KDIGO guidelines. And always when you order the lab test, we should be familiar with the assay used in our lab to get accurate reports. Also, the current KDIGO guidelines suggest BMD testing, bone mineral density assay using DEXA to assess fracture risk in patients with CKD. And bone biopsy is reserved for severe cases where we may opt for some treatment. Some treatment decisions may change based on the biopsy reports. So PTH and bond-specific alkaline phosphatase are used to evaluate the bone disease. High levels of these two parameters indicate a high turnover disease, and low levels of PTH and low bond-specific alkaline phosphatase indicate a low turnover disease. Also, KDIGO recommends to identify presence of vascular calcification by doing a lateral abdominal X-ray in all CKD patients, along with an echocardiogram to assess the presence of valvular calcification. So this completes the diagnosis of CKD-MBD. So to summarize, we have to assess biochemical parameters, calcium, phosphorus, alkaline phosphatase, and parathyroid hormone levels, at the time of diagnosis of CKD from GFR of less than 60 onwards. And serially, we have to monitor these levels to decide on the treatment options. Along with this, vitamin D, native vitamin D levels should be assessed and corrected if there is deficiency. Also, BMD testing is advised in patients with at risk for osteoporosis. And always remember that trends of the values are more important than a single value to decide treatment. Also, to identify vascular calcification, lateral abdominal X-ray and echocardiogram should be used. So, coming to treatment of CKD MBD, the four main targets are to lower the phosphate levels, maintaining serum calcium in normal levels as much as possible, correction of abnormal PTH levels, suppression of high PTH levels, and treatment of bone with bisphosphonates or other osteoporosis medications when indicated. So, treatment of CKD MBD, the main aim is to prevent adverse consequences of secondary hyperparathyroidism. So, the primary treatment is prevention and treatment of hyperphosphatemia by dietary phosphate restriction, use of various phosphate lowering agents, and in dialysis patients with adequate dialysis. Dietary phosphate restriction, it is advised to limit the dietary intake of phosphate to less than 800 milligram per day. But when we advise dietary phosphate restriction, always remember that high phosphate food products are mostly high protein, mostly or protein sources. So patients should not going for malnutrition when we are advising strict phosphorus restriction. Next is use of phosphate binders. We have different classes of phosphate binders: calcium containing phosphate binders, non-calcium containing phosphate binders, aluminum based phosphate binders, which are not commonly used now, and the novel classes of iron containing phosphate binders. Calcium containing phosphate binders, the major two drugs we use are calcium carbonate and calcium acetate. Non-calcium containing phosphate binders include sevelamer carbonate and lanthanum. Aluminium containing phosphate binders, we no longer use aluminium hydroxide, and iron containing phosphate binders, we have sucropheric oxyhydroxide and ferric citrate. So briefly about the different phosphate binders. Calcium containing calcium carbonate, they form insoluble phosphate complexes in the gut. The usual dose is 1 tablet 3 times per day with meals. 500 or 600 milligram of elemental calcium tablets are available. They are moderately effective. Advantage is relatively inexpensive, and the major disadvantage is with long-term use, chance of hypercalcemia and over suppression of PTH levels leading to adynamic bone disease. Also, there is a high risk of vascular calcification with long-term use. Non-calcium containing phosphate binders, we have sevelamer carbonate and lanthanum carbonate. Sevelamer carbonate is an anion exchange resin. It's available as 400 and 800 milligram tablets. 1 to 3 tablets per day can be used. Advantage, it's calcium free. It has an additional lipid lowering effect. Relatively more expensive, high pill burden, and GI adverse effects are the disadvantages. Lanthanum carbonate forms insoluble phosphate complexes in the gut. They are very highly efficacious compared to the other group of drugs. It's available in 500, 750, and 1000 milligram tablets. Maximum dose is 1000 milligram thrice daily. Disadvantages are expensive and has GI side effects, and long-term effects are unknown. Iron containing phosphate binders, we have sucropheric oxyhydroxide and ferric citrate. Advantages, it has iron, so additional iron supplementation can be avoided. Relatively low pill burden, but expensive and higher chance of GI adverse effects. So, as already discussed, the treatment of CKD MBD should always be based on serial assessments of calcium phosphate and PTH levels. Our target is to lower the elevated phosphate levels towards the normal range and avoiding hypercalcemia. In dialysis patients, we should be careful about the dialysate calcium concentration. And when we use calcium containing phosphate binders for long term, make sure that the dose of calcium is within the allowable limits, and calcium should be serially monitored. So among the phosphate binders, we usually choose phosphate binder based on the um, um, calcium and phosphorus levels. If a patient has a high calcium level, we usually choose non-calcium containing phosphate binder, either sevelamer carbonate or lanthanum. And patients with low calcium, we can either use calcium carbonate or calcium acetate. So that is about dietary phosphate restriction and phosphate lowering therapies, phosphate binding agents. Now, the third line of treatment is PTH lowering therapies. So, what is the optimal PTH levels in CKD G3A to G5 not on dialysis? Optimal PTH level is not defined till now. So, KDIGO suggests to see the trend of PTH and consider lowering PTH towards the normal range. And in CKD stage, CKD patients on dialysis, 2 to 9 times the upper limit of normal is considered the target range. So we have vitamin D analogs. The available one is calcitriol and also calcimimetics to treat high parathyroid hormone levels. Calcimimetic, the major drug which is available for our use is sinacalcet. Calcitriol is the active vitamin D analog. And sometimes in dialysis patients, we may have to use a combination of calcimimetic and calcitriol to maintain the parathyroid hormone levels. And in patients with severe hyperparathyroidism who fail to respond to pharmacological therapy, parathyroidectomy may be needed. So sinacalcet is a calcium sensing receptor agonist or calcimimetic. The starting dose is 30 milligram up to a maximum dose of 180 milligram per day can be used. With the advent of sinacalcet, there is reduced need for parathyroidectomy, but side effects are hypocalcemia and GI adverse effects. So another point is in patients with osteoporosis and high risk of fracture in early CKD, we have to manage just like general population guidelines. And in late CKD with PTH in the normal range with osteoporosis and high risk of fracture, again, as per the recommendations for general population, using bisphosphonates or denosumab should be considered. So to summarize, we have seen the difference between renal osteodystrophy and the systemic disorder of CKD, mineral bone disease. Renal osteodystrophy was the term which was previously used to describe the bone changes of mineral and bone abnormalities of CKD. But CKD MBD also includes the extraskeletal manifestations and biochemical abnormalities. In pathogenesis, we saw the role of the major hormones, especially the role of FGF23, along with PTH and calcitriol in the development of secondary hyperparathyroidism and the bone abnormalities. So, in diagnosis, the four major lab tests which we have to use and follow up are calcium, phosphorus levels, alkaline phosphatase levels, and intact parathyroid hormone levels. The trends of these lab parameters help us in guiding treatment. And treatment mainly dietary phosphate restriction, starting from early stages of CKD, along with use of phosphate binders and PTH lowering therapies. Among phosphate binders, we have to choose between calcium containing phosphate binders and non calcium containing phosphate binders based on the calcium phosphorus levels and the trends of these lab parameters. And in PTH lowering therapy, we have calcitriol, vitamin D analogs, and calcimimetics, mainly sinacalcet. So this among these medicines also we choose which one to use based on the calcium phosphorus levels. In patients with high calcium, we will prefer to avoid calcitriol and vitamin D analogs, and we'll prefer to use sinacalcet and or calcium sensing receptor agonists. But while patients are on sinacalcet, we should monitor serum calcium levels, and those who are developing hypocalcemia, we cannot continue on sinacalcet. So this is the summary of treatment of CKD MBD. Thank you. Any questions are there?
Aspirants, if you have any questions, please do ask.
Hello, ma'am. Abhishek here. Nice presentation and lot of information. I just wanted to ask one particular thing. What? How do you manage your perspective on the management of this calcium salt deposition in the vessels that occurs in these patients, especially when we see these patients coming to ICU? So any special take on that? I think it is called calcified laxation, if I'm not wrong. That deposition of the calcium salts across the vessels. Any your take on that?
Yes. For vascular calcification, mainly we have to focus on prevention, because early stages of CKD onwards, we have to focus on phosphate lowering therapies, and also serial monitoring of calcium, avoidance of hypercalcemia, avoid long-term intake of calcium-containing phosphate binders, and maintaining PTH levels in the normal range from the early stages of CKD to prevent vascular calcification is what we should do on patients with CKD. And for diagnosis of vascular calcification, we can use echocardiogram and X-rays. That also screening should be done from early CKD onwards, especially diabetic patients with high risk of vascular disease. So once vascular calcification sets in, the usual management, coronary artery disease screening and management as per the general guidelines should be followed.
Okay, ma'am.
Any more questions? So we can wrap up, conclude it.
Yes.
It was a nice session and interactive one. Thank you, ma'am.